Okay, so today we're going to talk about pericardial disease. So starting with the anatomy, so outside we have the fibrous pericardium, and then there's the serous pericardium, which has a visceral layer that runs alongside the inner aspect of the fibrous pericardium here. I'm sorry, the visceral layer runs alongside the epicardium here. So this covers the heart, and it covers the great vessels, the coronary arteries. And then there's the parietal layer, which is the outer layer of the serous pericardium. And then that is also the inner lining of the fibrous pericardium. And it's between those two layers where you can have pericardial fluid. So the pericardial cavity then normally contains only about 15 to 50 milliliters of fluid there around the heart. Now, the pericardium itself is usually easily demonstrated on CT or MR, especially anterior, where you get over the right ventricle. So here, that thin line represents the pericardium. So because we have fat beneath the epicardium, between the myocardium and the pericardium, this fat here, this epicardial fat, that kind of acts as a nice area of contrast, and then you have the mediastinal fat, which is outside of it. So between the two, you can see the pericardium. What is the normal thickness for the pericardium? Around 2 millimeters, but sometimes you can actually see it, so 2 or less than 2 millimeters. Sometimes you can actually see it on a radiograph. On a lateral view, if there's enough epicardial fat here, and then you also have some mediastinal fat, sometimes you can see that thin line as the line of the pericardium. Okay. So here's some more examples. So easily seen there over the right ventricle, so you can see it there on CT. Here on MR, when we have these T1 weighted images where the fat is nice and bright, you can see the pericardium there nicely. Okay. It's a little bit harder to see over the left ventricle, and it's very thin over the left atrium, so it's difficult to see back there over the left atrium. Anteriorly is where it's easiest to demonstrate. Okay. All right. Anything abnormal on the chest radiograph?
Well-rounded opacity at the right cardiophrenic
Yeah,
angle.
so there's an opacity here at the right cardiophrenic angle, so what do we think that might be? And you can see it here on the lateral too.
An epicardial fat pad?
Yeah, so that's a fat pad. It's actually in the mediastinum, right? So that's a mediastinal fat pad. What are features on the radiograph that help to tell you that that's a fat pad and that's not a mass?
The attenuation
Well, what do you mean by the attenuation?
is not as dense as like a...
Yeah, so it's not dense and you can see through it, right? So you can see the vessels pretty easily through it. It's not really silhouetting the diaphragm. You can see the vessels pretty easily through it. Also, the shape on the lateral view, this kind of shape that it has on the lateral view is also kind of typical. So the fact that you can see through it, it's lucent, that tells you that what you're dealing with is just a fat pad here in the mediastinum. Okay? So you can also have a fat pad there apically on the other side, right? Same idea. This one kind of makes the left heart border a little fuzzy, but again, you can see through it. You can see the vessels through it pretty easily. What's the arrow pointing to?
Pericardial recess.
Yeah, so this is fluid in the superior pericardial recess. So this is the most common recess, pericardial recess, that you'll see on CT. You want to recognize this as a normal finding. You don't want to mistake this for a dissection or lymphadenopathy. It's usually a fluid attenuation, and it's right there behind the ascending aorta. So we have these pericardial recesses. The transverse sinus here is this one over here, and the superior pericardial recess is part of that. And then there's the oblique sinus that sits behind the pulmonary veins. Okay? So the transverse sinus, this one here, is a pericardial recess. So it extends from the superior vena cava on the right to the region of the left pulmonary veins there. And the superior pericardial recess, also called the superior aortic recess, is part of that. And this is the part that's easiest to see on CT. So the oblique sinus is over here, kind of between the pulmonary veins and bounded inferiorly by the inferior vena cava. So the superior pericardial recess, though, that's the one that you want to be familiar with. That's the one we most often see on CT. You don't want to mistake that for pathology. Sometimes these pericardial recesses can come up pretty high, almost to the level of the aortic arch. And again, you don't want to mistake this for a dissection or any kind of pathology. Usually it's fluid attenuation, and you can kind of follow it down into the pericardial space on reformatted views. Okay, so sometimes this recess, especially anteriorly, can come up pretty high. Now, this looks like a nodule. Is that a nodule? What is it? So here it is there. What is it? No, it's not a lipoma. So this is fat attenuation, right? It's a little bit higher. This kind of helps you here too. If you look at, what is this structure? Which one? No, that's not the right superior. Who said that? Right inferior. Right. That's the right inferior. Okay. So you can see that the pericardial recess, there's a pericardial recess that can wrap around the right inferior pulmonary vein. Right. And on CT scan, sometimes if you cut that just right in cross section, it can look like a lung nodule. So it's usually fluid attenuation, and it's easy to tell on reformatted views, right, that you're dealing with a pericardial recess around the right inferior pulmonary vein. So you don't want to mistake that for a lung nodule. Right. What do we think of this case? First of all, what do we think of the heart size? Enlarged. So why is the heart big? Is it or is it not? Is it a pericardial effusion or is it actual? How do you know?
Is it Oreo sign on the
Yeah, so on the lateral view, you have the sandwich sign or the Oreo sign. So this lucency represents what? Epicardial fat. This lucency out here is mediastinal fat. And so the area in between, that thickening, is the fluid. That's thickening of the pericardial stripe. So thickening of the pericardial stripe on the lateral view is a sign of a pericardial effusion. Now, as far as the shape of the heart, it's said that it has more of an amorphous shape, or kind of, they called it a water bottle shape on the front of view. But this is pretty much a pathognomonic or diagnostic finding on the radiograph of pericardial effusion. And you see that sandwich sign or Oreo sign. Okay, so these are the findings that are associated with pericardial effusion: normal pulmonary vascularity despite cardiomegaly, sometimes obliteration of the retrosternal clear space. Might have widening of the subcarinal angle, but that sandwich sign or Oreo sign on the lateral view is the best for it. So CHF and pericardial effusion, it's not easy to tell them apart if you have a big heart. It's said that you can have more pulmonary venous congestion if you're dealing with, let's say, cardiomegaly here as opposed to a pericardial effusion. And easy on imaging, right? So we have pericardial fluid around the heart. That's easy to demonstrate. And also on T2-weighted images, of course, on MR, that's going to be very bright. So it's not too difficult to demonstrate. When you have a massively enlarged cardiomediastinal silhouette like this, what's the differential diagnosis? What could this be?
Tamponade?
Well, tamponade is the symptom, right? But you're getting at what are you saying this is? Large pericardial effusion, certainly, yeah. So it could be a large pericardial effusion. What else could it be? Pretty big, that'd be a pretty big mediastinal hematoma there, right? But what about a mediastinal mass? So where in the mediastinum? Well, if it obscures the heart borders, it's going to be what? It's going to be anterior mediastinum. So what's your typical large anterior mediastinal mass that might come down like that? Not thymoma, but you're close. What lesion from the thymus? Thymolipoma, right? Those are notoriously very large lesions. They can come down and drape over the heart like that, and they can't simulate an enlarged heart. What if this is a big heart, really? What if this is the heart that's enlarged? What would cause that? what would cause a big heart? Cardiomegaly from what? You said cardiomyopathy or multivalvular disease, right? So it's more than one chamber is involved. So more than one valve might be involved. Right? So those are some of the things that you think about when you see a chest radiograph like that. In this case, the answer was pericardial effusion, right? Pericardial effusion. So especially in a young patient, we've mentioned that before. When you have a big heart, always think about pericardial effusion, and don't forget to recommend echo in those cases. All right, so what kind of study here? What kind of view? Yeah, it's a 4-chamber cardiac gated MR, bright blood imaging. What's the finding? Yeah, so we can see, so, you know, as we go through the layers here, what am I pointing to here? What is this? Yeah, so that's the anterior wall of the right ventricle. That's myocardium. What is this white stuff out here? That's epicardial fat. Okay. This guy over here, you can see a little bit of it. What is that guy? Yeah, it's the right coronary artery. Right. So this stuff here, this is thickened pericardium. And in between, you have this pericardial effusion. Now, is there something peculiar about it? Besides the thickened pericardium, you also see septations, right? So what could this be? What could cause oculated pericardial effusion like that with septations? What could do this? Infection, right? Certainly, right? So you might have an infectious pericarditis, essentially an abscess there like that in the pericardium. Is there anything else that could do this? Complex pericardial effusion? Yeah, metastatic disease, right. So those two are going to be big on your differential, usually clinically pretty easy to differentiate. So this was bacterial pericarditis causing these septations and markedly thickened pericardium. Okay. What about this CT? What does this demonstrate? So there is a pericardial effusion. Is there anything to note about it? It's high in attenuation, right? So you have a high attenuation pericardial effusion. What does that mean? Blood, right? Hemopericardium. What are causes of hemopericardium? Trauma, direct trauma, right? That can cause hemopericardium. What else? Dissection, sure. So a dissection that's bleeding into the pericardium, right? What are other causes of hemopericardium? Malignancy, anything else? Coagulopathy, right? It's pretty rare to cause that. That can also cause hemopericardium. Sometimes also it can be associated with myocardial infarction. Sometimes myocardial infarcts can be complicated with hemopericardium. Okay, so these are the various causes of hemopericardium. Give that to you. And on T1 weighted images, that can have high signal intensity because of the blood products within the fluid. Okay. So here's an example of hematoma after a myocardial infarction in this patient. So there's high signal here, but there are these areas of hematoma here within the pericardial fluid. So you have this kind of complex pericardial fluid collection, and in this case, it was a complication of infarct. What's going on here? There's an aortic dissection. What's interesting about it? Well, what about the pericardium? That's even denser than blood, right? That's contrast, right? So yeah, the patient has hemopericardium, but in addition, the patient's actually leaking contrast into their pericardium, so it's actively bleeding into the pericardium here. And that's contrast in the pericardium. So here's another patient with a pericardial effusion, right? So here's the pericardial effusion. Any idea why this person has a pericardial effusion?
Cancer.
How do you know? There's a lung mass, right? It's right lower lobe lung mass here associated with the pericardial effusion. So you need to suspect that this might be a malignant pericardial effusion. Okay, so this was from lung cancer. There's a mass there, even on the radiograph. Right? So this person had a motor vehicle accident. You can see this fluid here, chest tube, some pneumothorax. Anything else?
There's pneumopericardium.
Yeah, so there's pneumopericardium, right? But also look at the shape of the heart.
It's squished.
Yeah, it's very distorted, right? So you see how the heart is distorted and there's air around it, okay? So what should you think about here? What?
Is it prolapse?
Well,
Or
you
herniation?
so what, strangulation from what?
Or herniation?
Yeah,
or-
herniation of the heart through the pericardium. So if there's with trauma, it's rare, but with trauma, you can get tears of the pericardium. And when that happens, sometimes the heart can actually herniate through the tear. So, you can have air, of course, in the mediastinum and also in the pericardium. But if you have air like this surrounding the heart in a trauma patient, and the heart has a peculiar shape, it looks like, it's being squeezed over here. So that's where it's herniating through the pericardium, right? So this is an emergency, so this requires immediate surgery to fix this, right? So as we come down here, you can see the pneumothorax. Now we start to see the air around the heart, and then the very distorted shape. And you can almost imagine the tear in the pericardium as you follow this down, right? So here we come down here, come down over here, and then it looks like something is torn in here. Okay. You can see it here too. Here's another example. This one was just pneumopericardium as a result of trauma, some air outlining the heart, and you can see it here too in this case, some air just outlining the heart associated with pneumothoraces and pneumomediastinum. This is a massive pneumopericardium. And then this is one with an air fluid level pneumopericardium. This patient has chest pain, abnormal EKG, and what are the findings here on MR? Yeah, so there's marked enhancement of the pericardium after contrast. And on the dark blood images, what do you notice about the pericardium? Yeah, it's thickened, right? So what's your diagnosis? Acute pericarditis, right? So this patient has enhancement of the pericardium with a thickened pericardium, symptomatic. This is acute pericarditis, okay? So we can look for this with MR. What we look for is the thickening of the pericardium, but also importantly, we look for enhancement of the pericardium. Right? So here's another patient who has enhancing pericardium, right? See that? So why is the pericardium enhancing in this patient? What's this patient's problem? They have an infarct. How do you know it's an infarct? Yeah, so you can see here that there's also enhancement on the short axis view for what vascular distribution? LAD, right. So there's enhancement of the myocardium here, involves the endocardium. What's this dark area? Microvascular obstruction. What does that tell you about the infarct? It's an acute infarct. So here's a patient who has an acute large infarct. And so here we have pericarditis that is associated with the infarct. So pericarditis can be associated with acute myocardial infarctions also. So in addition to enhancement of the myocardium, you might also see enhancement of the pericardium in some of these cases. Okay. If I tell you this patient has a history of myocardial infarction 4 weeks ago, now has chest pain, and also has a sizable left pleural effusion. So what is that?
Post-MI
Yeah, so post-myocardial infarction pericarditis, that's Dressler syndrome, right? So they can have pericardial effusions and pleural effusions 2 to 10 weeks after infarction. Most commonly, the effusions on the left side. Occasionally, the pericardial effusions may be hemorrhagic, so it requires steroids to treat. This can also occur after surgery, after post-pericardiotomy. So it's called post-pericardiotomy syndrome. So it's thought to be an autoimmune hypersensitivity reaction to some proteins that the patient is exposed to when the pericardium is violated. Okay? So usually small to moderate pericardial effusions, often associated with pleural effusions, and can be treated with steroids. Right? So here we have a series of axial right blood scintillating images going through the heart. Yeah, so there's a big right pleural effusion. There's also a big pericardial effusion. Is there anything else we need to notice?
Seems like it's constricted.
So what's the term you want to use here then? Tamponade, right. So what are the findings associated with tamponade on imaging?
Equalization of the ventricular pressures, right?
Well, what do you see on the imaging?
Hypokinesis.
Well, you see the collapse. You see how the distortion, especially of the right-sided chambers. So collapse of the right atrium there, distortion of the chambers on the right side. They are the lower pressure chambers, right? So those are more easily affected by space-occupying processes in the pericardial space. So the problem with pericardial effusion and tamponade is that it can restrict filling of the heart. And so we might see then this effect where we see distortion of the chambers caused by the pericardial fluid. Right? It's another example, pretty much the same thing, big pericardial effusion, and then you see how it distorts the chambers there, especially on the right side, especially the right atrium. So cardiac tamponade, the heart size may be normal if the pericardial fluid accumulation is acute. Usually no pulmonary edema. You might have dilated SVC, IVC, and azygous vein. Right? And the problem is it's going to decrease the venous return to the heart, which will decrease the cardiac output. So can be associated with large effusion, compression of the right atrium and the right ventricle, diastolic collapse of the right ventricular free wall, also right atrial compression during early systole. Right? Inversion of the interventricular septum, so that might be bowed towards the left side. And we talked about distension of the IVC and hepatic veins. Okay. Patient had a stab wound to the chest, initial chest x-ray looks okay. 6 hours later, it looks like this. What are we thinking about? Yeah, hemopericardium, right? So when you have an acute enlargement of the cardiac silhouette there on a chest radiograph, think about pericardial fluid in the setting of trauma. This was actually hemopericardium. You can also see some distension of the IVC. In this case, it's a periportal edema. So what do we think of this case? Well, what's the finding? Yeah, there's marked thickening of the pericardium. Right? So again, when you go through the layers, so this chamber is right ventricle, this guy. Yeah, so that's the anterior free wall, the right ventricle. This white stuff is epicardial fat, this guy over here, RCA, this stuff out here, mediastinal fat. So between the epicardial fat and the mediastinal fat, you have marked thickening of the pericardium. You can see that on the coronal image too. Right? So in this coronal view. So if you're evaluating with the pericardium with MR, in addition to your routine views, I would also recommend doing coronal views. It gives you a nice view of the pericardium there. Right? So what's the complication of thickened pericardium? Constrictive pericarditis. Yeah. In this case, this was also enhancing, so there was an inflammatory component for this patient. So the finding on the chest radiograph that's associated with constrictive pericarditis is calcification of the pericardium, pericardial calcification. Often it's easier to see this on the lateral view, right? If it tends to be chunky like this, right? Chunky pericardial calcification is associated with what? Tuberculosis, right? So worldwide, TB is a very common cause of constrictive pericarditis, not so much in the United States. In the US, it's usually more related to surgery, but worldwide, tuberculosis is a common cause of constrictive pericarditis. Now, given that this patient has pericardial calcification, right, are there any clues on the CT that it's physiologically significant, that this patient might have constrictive pericarditis?
IVC's.
The IVC is distended, yeah, so you have distension of the IVC in the hepatic vein, so that's important. Anything else?
Pleural calcs on the right.
Well, the pleural calcs don't tell you that you have physiologic significance of the pericardial calcification, right? So I'm asking what findings on the CT tell you that these pericardial calcifications are physiologically significant?
Is the right ventricle?
So you might wonder, is there some distortion of the right ventricle, right? That's important, but what about the atria? What do you notice about these atria? Yeah, they're dilated. So the atria are dilated, right? So any distortion in the chambers of the heart associated with calcification of the pericardium, then you have to think that this is physiologically significant. It's causing constrictive pericarditis, right? So causes can be post-op, radiation, after inflammatory conditions like viral pericarditis, TB, infections, uremic pericarditis. So there's increased left atrial pressures, there's going to be increased pressures because it's hard filling the heart. That can lead to pulmonary venous hypertension, and this can also mimic restrictive cardiomyopathy. So sometimes they'll send a patient to imaging to differentiate between restrictive cardiomyopathy and constrictive pericarditis. So don't get those two confused. For restrictive cardiomyopathy, we're looking for myocardial abnormalities. For constrictive pericarditis, we're looking for pericardial abnormalities. All right? So this is strongly associated with pericardial calcification. 90% will have pericardial calcification. It said that 50 to 70% with pericardial calcification will have constrictive pericarditis. So on the chest radiograph, if you see that on the chest radiograph. So look for flattening of the right heart border, pulmonary venous congestion, dilated atria, especially the left atrium, dilated SVC and azygous vein. Of course, thickened pericardium. So pericardial calcification, right? So we look for that. And sometimes it may not be very obvious, right? So this patient had surgery, had a history of surgery, so you can see some calcification there. Often it's easier to see on the lateral view, this pericardial calcification. So pericardial calcification, dilated atria, distorted tubular ventricles, dilated IVC, those are clues on your imaging that the calcification is significant in terms of causing physiologic problems. So here the IVC is dilated, also the coronary sinus is dilated in this patient with the pericardial thickening. In this case, we can actually see some there's distortion here in the shape of the ventricles here, right ventricle and the left ventricle, distorted shapes of the ventricles here. So that tells you that this is physiologically significant. So pericardial thickening, if it's greater than 4 millimeters, it's definitely abnormal. 2 to 4 is kind of the gray area, but greater than 4 is definitely abnormal if we have pericardial thickening. What are we looking at here? So what kind of view? Yeah, so this is a short axis view. How is this different from the other MRs that I've shown you?
Is the left ventricle hyperdynamic?
Yeah, but what's different about when you just look at this and look at the images here?
So much detail on the lungs.
What?
You see a lot of detail on the lungs here.
Look at the diaphragm. What's happening? Yeah. So what are we asking the patient to do here? Yeah. So usually, remember, MR is usually done with breath holds, right? So usually image with breath holds. In this case, we're actually asking the patient, and we're imaging kind of in real time. We're asking the patient, take continuous deep breaths while we're imaging, right? Why are we doing that? So what is it going to show us? And what does it show here?
Seems like there's bowing there.
So what's happening to the interventricular septum?
Bowing sort of into the right ventricle.
Well, it's actually, yeah, it's flattening and moving towards the right ventricle when? On inspiration, right? So on inspiration, there's flattening of the interventricular septum and it moves towards the left ventricle. Why is that important? What is that associated with? Is that normal? No, it's not normal. Remember, the pressures in the left ventricle are always higher than the pressures in the right ventricle. The interventricular septum tells you is a reflection of the pressure gradient. Both ventricles are pushing on that. So it should always be convex towards the right ventricle, right? But in this case, it's flattening out, right? So what condition gives you this? What topic were we just discussing? Constrictive pericarditis. This is a manifestation of constrictive pericarditis. So you mentioned that when the patient takes a deep breath, it increases venous return to the right side of the heart. What's the problem with constrictive pericarditis? The problem with constrictive pericarditis is that the pericardium is very stiff and it constricts the heart in the sense that the ventricles have lost their independence. Right? So when one ventricle increases in volume, it can occur at the expense of the other ventricle. So when we ask the patient to take in a deep breath, right, it fills the right ventricle, but because the pericardium is constricting the heart, the left ventricle can't fill. And so then we get the interventricular septum being pushed towards the left ventricle. So the flattening of the interventricular septum on inspiration, this is a sign of constrictive pericarditis, okay? And that's what we look for. So this is normal, right? So you see, patient takes a deep breath. See that should always be convex towards the right ventricle. When we have constrictive pericarditis, you get flattening. So this is constrictive physiology, okay? Now, this has also been called a septal bounce. Sometimes you can see how you get that kind of paradoxical motion where it flattens and bounces back, that abnormal septal motion, early diastolic septal flattening. That's also associated with constrictive pericarditis. And so this finding, this flattening of the septum, helps you to differentiate constrictive pericarditis from restrictive cardiomyopathy. We don't get this with restrictive cardiomyopathy. Okay? So, as we talked about, the constrictive pericarditis impairs the ventricular expansion, and so that's why you'll get that movement of the interventricular septum towards the left ventricle, and then it bounces, back. Okay? Most pronounced at the base. Some thickening here of the pericardium, not so much, but when we do the exam, we do see that there's a significant component of constrictive physiology, even though the pericardium is not that thickened in this patient. All right. What's abnormal here? So this is kind of an Aunt Minnie, and there are findings on the chest radiograph. So what are the findings on? So you said this was congenital absence of the left pericardium, and the findings on the chest radiograph associated with that, what are they?
Left lateral displacement.
So the heart is displaced towards the left. That's one. Two? What's number two?
Elevation of the apex.
No. Why does the apex look elevated though? Well, what's underneath the heart?
Oh, there's
Lung tissue. Lung tissue gets underneath the heart. Why? Because there are no pericardial attachments. So because of the lack of the pericardial attachments, there's lung tissue that gets underneath the heart. So that's two. What's number three? What's going on here? Notching in the AP window. Right? Usually there's pericardium in the AP window, but if you have absence of the pericardium, then lung tissue gets into the AP window, and you get this notching in the AP window. So lung tissue in the AP window. So it's nicely illustrated here on the CT. There was one exam where they just gave you this image, and you had to come up with the diagnosis of absence of the pericardium because this lung tissue was getting into the AP window. Okay? So, heart deviated towards the left, Lung gets underneath the heart because of the lack of the pericardial attachments, and lung getting into the AP window causes the notching along the AP window. Okay? Congenital abscess of left pericardium. There, you can also have, so this is usually left pericardium that's missing. 30% have associated anomalies, so you have to look for other things like ASDs, VSDs, bicuspid aortic valve, PDA. So in 30% of cases, there are other findings or other abnormalities that can be associated with this. Okay? So that's absence of left pericardium. Many patients can be asymptomatic with normal cardiac function. So we talked about all of these findings already. Now, there is something that's even more unusual, partial absence, where the pericardium is just missing over the left atrial appendage. So this is somewhat more dangerous because here you can get herniation of the left atrial appendage and strangulation through the defect in the pericardium. So this is partial absence of the pericardium, and you might get herniation of the left atrial appendage there. Okay. Here we have a patient who has what looks like a mass here, right, over the heart, and here's the MR. So what are we dealing with here? Pericardial lymphoma? Lipoma. What's the signal characteristic there? It's very bright, yeah. So this is fluid, right? So this is a pericardial cyst, right? That's a pericardial cyst. So on CT, these can be fluid attenuation, T1 weighted imaging, lower in attenuation, although they can be higher than fluid because of proteinaceous contents. They're usually very bright on T2 weighted images. So that's a pericardial cyst, right? These do not communicate with the rest of the pericardium, right? So you get this, can be either in the right or left cardiophrenic angle, usually a little bit more common on the right. Not too hard a diagnosis. Is this a cyst? No. What is this? How do you know it's not a cyst? It's enhancing. This is a mass. So what's the most common cause for pericardial mass? Metastatic disease, right? So what are the tumors that metastasize to the pericardium? Lung, certainly, yes. Breast. So any tumor can do it, but those statistically are somewhat higher on the list of tumors that can metastasize to the pericardium. Right? Now, here's another very ugly looking pericardium here. What primary tumor of the pericardium would this be? If I tell you it's of course, metastatic disease is first on your list, but if I tell you it's a primary tumor, what's the...
Angiosarcoma.
No, angiosarcoma is not the pericardium, right? That's when we do with cardiac tumors. So what's a tumor of the pericardium? Pericardial. Well, that's an important point. It's a sarcoma. It's not a carcinoma, right? Pericardium is connective tissue. So what do we call that tumor? You want to be upset when I tell you? Mesothelioma. Right? Just like you can get mesotheliomas in the pleura, you can get them in the pericardium, and you can also get them in the abdomen, right? From the lining, the peritoneal lining. It's mesothelioma. Rare, but it can occur. Pericardial mesothelioma. Usually big ugly tumor associated with, of course, pericardial effusion. Okay. So pericardial mesothelioma. 50-year-old man with chest pain has this funny looking thing next to the heart there, and on CT it looks like this. Well, it is fat, right? But the patient is having pain. Patient's having pain, right? So yeah, this is fat, but what's unusual about the appearance of this fat? Well, not so much an answer, but it looks kind of very dirty in there, right? So looks like there are inflammatory changes in there, right? So what would do this? What do you call this? Well, if this were in the abdomen next to the colon, you would call it appendigitis, right? Epipleural appendicitis, right? This is very similar, epipericardial fat necrosis. Right? So what's the cause? Is it a torsion? Is it an infarct? But the fat, you can get an infarct of the fat there next to the pericardium. And that will present just like an MI. A patient will have acute pain. Self-limited usually gets better in a few weeks. Might give you an opacity like that next to the heart. But on CT, you can see that there's inflammatory change there within the fat. Okay, so fatty lesion adjacent to the pericardium, inflammatory change, stranding of the fat. You might have thickening of the adjacent pericardium. You might have some associated pleural effusion. That's epipericardial fat necrosis, and it's usually self-limiting. It gets better on its own in a few weeks. Okay. Another example, very dirty-looking fat there, and it's gone a few weeks later. Epipericardial fat necrosis. Okay. All right, so let us move on to the quiz.